to our YouTube channel. Still on the series Subspecialties in Internal Medicine. It's more than an honor and pleasure to be doing oncology today. Good day, Doctor. Good day, Prof.
Welcome to the medical students from the faculty.
So if you could please briefly introduce yourself, your qualification.
Well, I'm Professor Paul Ruff. I'm head of the Division of Medical Oncology in the Faculty of Health Sciences in the School of Clinical Medicine. I've been head since 2000.
What's an oncologist?
Okay, so let's say what is a medical oncologist, which is what we do, is we treat cancer or in all its forms, and normally we divide cancer into two big groups, being solid tumours, which is probably 80% of what we do. We do breast and bowel and lung and liver and kidney, etc., etc., and then hematological cancers, which would be leukemias, lymphomas, myelomas, which is about 20%. Clinical hematologists also do the hematology. There's a bit of overlap. But, you know, we treat here all cancers with medical means. Now, what is a medical treatment of cancer? There are many different forms. Most people think of chemotherapy. And the term chemotherapy is actually a very broad term. I mean, in reality, all medicines are chemotherapy. Antibiotics are also chemotherapy. But there's always been the term cancer chemotherapy, and then everyone gets scared because it causes terrible side effects. But the reality of this picture is it's very much more complicated than that. And there are many approaches towards the treatment of cancer. And the management of cancer medically has changed drastically in the last 20 years.
So, in a nutshell, what is oncology?
To clarify what we mean by oncology, I mean oncology is it's treatment of cancer, but in fact oncology has various sort of subsections, and in fact it's a bit disjointed, which is one of the problems. Ideally speaking, what we really need would have a dedicated oncology or cancer hospital institution, because medical oncology that I do and run the department falls under internal medicine. Radiation oncology, which is a separate section of oncology, although we work very closely together with them, falls under the Department of Radiation Sciences. Surgical oncology falls under the Department of Surgery. Gynecological oncology falls under the gynae department, etc. And so it's actually disjointed. Obviously a way around it, and something we do on a regular basis. We have what we call multidisciplinary meetings, and we have quite a few every week. You know, we do one for breast cancer, we do one for GRT cancer, we do one for gynecological cancer, etc., lung cancer, urological cancer, where you get the appropriate people together. So you get the medical oncologist, radiation oncologist, the appropriate surgeon, be it a gynecologist, surgeon, urologist, etc. Plus, ideally, which we try to do, is have radiology there, so that you can have the radiology support, pathology, etc. So, if you have a multidisciplinary team with a multidisciplinary meeting, it's the best way to provide comprehensive cancer treatment. But now, in the last 20 years or so, there's been a move towards what is known as targeted therapy. Now, the term targeted therapy is a bit of a misnomer, because everything's targeted in one way or another. But it's a nice fancy way of saying that. They're trying to say, oh, it's more specific, therefore less side effects.
What inspired you to be an oncologist and your journey? Like, it's been 40 years in
I'll tell you what happened. When I was an intern, my very first day of my internship, the very first patient I saw was a woman who was in her 30s, who was pregnant and had acute leukemia. I was obviously the most junior person there, and this lady had a rough time back then in 1980, who didn't have quite the resources we have today, but she did very well actually. where she is now, but all I know is the child grew up to become an adult, and she's probably got grandchildren now, but this lady did well in spite of lots of hiccups along the way. And I think that's what got me interested in cancer. I got interested and then, sort of did my registrarship and started doing oncology. Then I went and spent a few years in the United States, in Boston, doing some more research. Actually, I was involved more in red blood cell research, was more involved in hematology, and then came back here and carried on with oncology ever since.
Is the process of becoming an oncologist same compared to the 1980s as now?
Look, basically, no, it's much more formalized now. I mean, then it was pretty ad hoc. I mean, now to become an oncologist in South Africa, it's going to take you from start to finish as long as it takes from when you're born till when you start medical school. I mean,
18?
17, 18 years. I mean, it's medical school, which will be 6 or 7 years. Then your internship, another 2 years. Then your community service,
yes,
another year. Then possibly a year of medical officer before you get a registrar post. Then a registrar. Now there are 2 ways you can do it. You can become a registrar in internal medicine, which is 4 years, and then do medical oncology after that, because it's a subspecialty of internal medicine, which is another 3 years. It comes to about 18 years. Or what some people do is they go straight into radiation oncology, which is just 4 years post your internship community medicine. So whatever it is, it's a long process. And remember that it's while you're along the way, I mean, once you graduate, I mean, you are earning. When you're in training positions, interns, community service, in-house registrars, fellows, whatever. I mean, you are earning a living. It's not like you're a student all the time. But, remember one other thing in medicine, that you're always learning. There's no such thing as that you get to a point where you stop.
Just to back up a bit, so I'm assuming you both in practice and in research.
Yeah, well, I mean, I like doing different things. I mean, most people, do one thing. I think the one way that keeps me going is to have my finger in a few times. It's not interesting. So, I do a lot of different things. I mean, head up the department at the faculty and at this hospital. We also have a new satellite medical oncology clinic. We've just opened at Kunene, basically to try and expand, which is, it was always only here. But so, my role here is more in a sort of administrative and advisory capacity. I don't see patients individually anymore. I have more to advise. I mean, obviously do ward rounds in the inpatient clinic, and then at the same time do teaching at undergraduate and postgraduate level, and then research. And we have different forms of research. I mean, we have quite a big team that with the Wits Health Consortium doing clinical research, which is not always, but a lot of it's sponsored by the pharmaceutical industry. We then have grant-funded research with projects that are funded either locally by the Medicine Research Council in South Africa.
You're such a jack of all trades. You're busy juggling many things. Can you still manage like a healthy lifestyle,
Well, as I was saying, you need to have a balance and you need to have time set aside for various things. It is difficult, I must be honest with you, and it can interfere with your sort of home life. One thing that's made it much more difficult, I must say, has been the advent of COVID and the advent of virtual meetings, because in the past when you had meetings, you'd go somewhere, have a meeting, go home. Now they say, well, you can do it home, you can do a meeting. So you end up having meetings till 10:30 at night, or meetings on weekends, because, you can, you just at home, you put on your computer and you do a Zoom or a Teams meeting. And the boundaries have become much less now than they used to be. And I think it's a problem because all of this stuff gets intrusive into your life. and it's problematic, and I think it's something we're going to have to get the solution for. Because I've definitely found that it has become a lot more intrusive now than it used to be. Because before, if you have a meeting wherever it is, you go to Pretoria to the health department, you go have a meeting, go home, that's it. Now it doesn't work that way. So things have changed a lot with COVID. I mean, the advantages of all this virtual stuff, but there are also major disadvantages of it.
And it's one of those things, like with whole oncology now, it's just really you're drawing me into oncology, so I'm considering it maybe. And something just off, quick question, just like what are the personal attributes a person should have, like to do oncology, like for me to become a medical oncologist, what do you think I need personally?
You need commitment, number one, because it's a long haul. And whatever you do, I mean, you've already started a commitment by doing medicine, and this is a continuation. But it's something you have to be committed to. I mean, you're right, you need a balance, and you need to also have an outside life, and I think it's very important that you do. No one must only work. But you need to be committed, and you need to work hard. You can't just cruise along. I mean, it helps if you've got a good memory and you're clever, and it helps a lot. But if you don't do any work, you're not going to get anywhere. And you have to work very hard.
Yeah.
You have to, read. You have to interact. And so, I think the first thing you need is commitment.
Commitment.
The other thing is, it has its hurdles. Everything has its hurdles. I mean, it's a field, and I know some people have not wanted to do oncology because they think it's too hard, and have done other fields. I mean, for example, if you want to feel, I've had a good friend of mine who did dermatology because he said there's no nights and weekends. There's this reason, which is not a good. I don't think that's a good reason, but it's a field that you have to work hard. It's very sort of consuming of your time, but also it's emotionally consuming. But everything you do is. But I think oncology, in some ways, has something which maybe not anything else has. Is that a lot of your patients die, and although a lot of your patients don't, and I mean, your prognosis of having if you've got end-stage heart disease is worse than with a lot of cancers. But patients do die, and you have to get used to that. So you do develop a sort of shield to some extent. I mean, but you have to have a balance. Once again, you can't become hard and nasty, but you have to also have a shield to protect yourself, because you cannot get emotionally involved every time a patient dies. And every time you have to talk to a patient or a family and say, I'm sorry, but we can't do anything. And so, I mean, you get good at that over the years. And you have to learn to be honest. I think honesty is very important. Lots of doctors are very dishonest. They tell the patients what the patients want to know. And that's not always the right thing to do. You have to have a balance.
Yeah.
You have to keep the patients positive and optimistic, but you also have to be realistic. So you need a balance. If the doctor tells you there's nothing to do, you're going to die, that's terrible. The doctor tells you, oh, don't worry, we'll cure you, that's also wrong. You have to have a balance so that and that you develop over time. And that's a difficult part of oncology, is dealing with death. There's one other thing that doctors need to learn, and I think this is probably the most important thing that doctors need to learn more than anything else, which most doctors don't know, is you have to learn what you don't know.
And finally, just closing remarks now, like advice or tips that you'd give to students like myself and Ntokozo here, like
the one other thing with oncology, you need to have an interest in science, and this is something I've always pushed. A lot of the fields don't, and I push basic science. I think it's very important. And in fact, during our exams, a quarter of the exam is basic science, which includes molecular biology, pharmacology, cell biology, and that. And it's important that you understand the sort of fundamentals of how cancer works and how the medicines work. So to have a good scientific background as well as a clinical background is important. You know, a lot of clinicians don't really know anything about science. But I think it's a field that lends itself to science because of the fact that cancer is essentially a molecular disease, and you have to understand the molecular basis for the disease and the treatment. And so if you have an interest in science, in basic science, in molecular work, cancer oncology does lend itself to that. And then there's one last area which no doctors understand, and I think it's something I've been encouraging that it be brought into the undergraduate curriculum, but up until now there's been resistance. The previous dean was very unhappy when I mentioned it, is health economics. Because I think the understanding of the economics of health, especially practicing in this country, if you don't understand health economics, you don't really know what you're doing.
True.
And I think it's very important that medical students be taught about health economics. And that goes hand in hand with ethics and things like that, because you know you have to also learn to make difficult decisions. And understanding the economics of medicine in general, cancer in particular, is very difficult.
And just lastly, what's the state of medical oncologists like we have? How many do we have in ratio?
Country.
Yes.
Probably about 30.
Excuse me?
Yeah.
Pardon me?
Yeah.
30?
That's, if you're a medical and radiation oncologist, you put them all together, you've probably got about 150.
But oncologists?
No, about 150. No, we're very short.
Oh, so they need us, guys.
Yeah.
Let's consider.
There's major shortages of all sorts of things.
Are they posts though?
That's the problem. There aren't posts. Because that's the health department's role. They don't pay posts. Because there's always money issues, as you know. I'm not going to go into all that now, but you know.
I would just like to thank you, Prof. And it's been 40 years sailing on, more than 40 years sailing on in the medical field. So I'm proud to say I'm sitting with a medical oncology giant. And it's more than an honor and a privilege to have interviewed you and draw some actual wisdom regarding oncology. And any final words from your side, Prof?
No, just to say thank you and to wish you guys all well. Your interest and enthusiasm is great. I'm always get excited when I see, students and young doctors who are keen and interested in doing things beyond their day-to-day. It's always, you need that. And there are a lot of people who really do a lot of things, and that's what you need. And, the aim now for us is to try and develop, to build capacity. I think it's very important is to build capacity for the future. You're the future.
But thanks a lot, Prof. Thanks a lot.
All right.
And we'll see you guys.
Hey everyone, for this video's random medical fact, did you know that our body can grow tumors called teratomas which contain all sorts of different tissues, from muscle to bone to hair and even teeth? In fact, medical literature has reported teratomas up to 40 kilograms in size. Pretty gross, right?